and more specifically, substance use amongst young people and caregivers in child protection systems. We actually reached registration capacity on this webinar and had to open up further to meet demand, so I can't wait to tell you more about what we're doing today and our speakers. First of all, I'd like to acknowledge that I'm broadcasting from Wurundjeri land, which was never ceded. I wish to extend this acknowledgement of the traditional custodians of the various lands on which we are all tuning in from today, and to pay my respects to their elders, past, present, and future. If this is your first time tuning in, we at the Monash Addiction Research Centre bring together world-leading expertise from across Monash University and the sector to provide national thought leadership, education and research excellence to develop, deliver and evaluate effective policy and practice approaches for addiction. Our interdisciplinary webinar series brings together addiction researchers, clinicians and other experts to discuss emerging research and challenges in the addiction field. So we'll be covering a range of topics today, and the speakers have asked me to flag that there will be some sensitive content ahead. Topics will include the sexual and criminal exploitation of children and the supply of drugs to children. If you find any of this content distressing, we encourage you to take care of your well-being and switch off or leave the webinar. There are some phone numbers up on screen if you'd like to talk to someone, noting that Blue Knot are trauma specialists. These same numbers are also listed on the event's Eventbrite registration page, which will continue to be accessible after this live webinar ends. We have a really stellar lineup today from a range of backgrounds, and I'm proud to be able to introduce our three speakers. First up, we have Dr. Susan Baidawi, who is a Senior Research Fellow at the Department of Social Work. She holds significant research experience at the nexus of the child welfare and criminal justice fields. She has conducted and authored outputs for numerous studies, reviews, and evaluations in the child protection, out-of-home care, leaving care, and youth justice fields. Dr. Baidawi is funded by an Australian Research Council Discovery Early Career Research Award, a DECRA Fellowship, for the project Dual Child Protection and Youth Justice Clients, expanding the evidence base. This project investigates the phenomenon of children who cross over from statutory child protection systems into youth justice systems, and is being conducted in partnership with the Children's Court of Victoria. After Susan, we'll have our second speaker, Associate Professor Debbie Scott. Associate Professor Scott is the strategic leader for the National Addiction and Mental Health Surveillance Unit at Turning Point. She's a public health researcher with a nursing background and applies that perspective to the use of data to inform the development of policy and prevention strategies. Her research focuses on surveillance methodologies and the use of surveillance data to improve the understanding of the role of alcohol and other drugs in intentional injuries such as family violence, child maltreatment, self-harm, and suicide. Associate Professor Scott has collaborated with the World Health Organization, UNICEF, and the International Society for Prevention of Child Abuse and Neglect on data quality issues and surveillance methodologies. And our third speaker is Dr. Christine Grove, who is an educational and development psychologist, Fulbright scholar, and senior lecturer. Dr. Grove works collaboratively with healthcare professionals, teachers, parents, and young people to support the individual and unique needs of youth. Her research lies in engaging with the young person's perspective and experience. As a psychologist, Dr. Grove has worked in schools, hospitals, and in private practice in various supporting roles with young people and their families. Her doctoral research examined interventions for children of parents with a mental illness, which received the Lewis and Lewis Educational and Developmental Psychology Postgraduate Research Award. If you have any questions for our speakers, please use the Q&A Zoom function down the bottom of the screen as opposed to the chat box. The questions will either be answered during the session or during the Q&A session led by Christine at the end of the webinar. And without further ado, I will hand over to Dr. Susan Baidawi.
Thanks, Tina. Just share my screen. Okay, can you see that? All good? Okay, great. Thanks for having me today. I'd like to begin by acknowledging the traditional custodians of the lands on which I'm coming to you from today, the Bunurong people of the Kulin Nations. I pay my respects to their elders past, present and emerging, and I extend those respects to all First Nations people joining us today. I'm going to speak to the topic of crossover children, and I'll go a bit more into who this group of children and young people are, certainly very pertinent to the broader topic of vulnerable children and vulnerable young people, because I would have to say that these are among the most vulnerable young people in Australia today. Probably a bit to say about even the use of the word vulnerable, which I know can be a bit conflicted. There's also an enormous degree of resilience shown by this group of children and young people that we also should not look past. But I really want to focus on the connections between childhood adversity, substance use and youth offending in this cohort. A lot of the data I'll be sharing with you today is drawn from an ongoing study I've been conducting in partnership with the Victorian Children's Court since 2016. A large part of that study was involving detailed case file analysis of children who had come before the criminal court when they were aged 10 to 17 years, and who also had a history or a current involvement with the Child Protection Division of the Children's Court too. So I'll be presenting some data from that component in particular. But who are crossover children? This is a group of children and young people for whom there are significant and long-standing concerns. They are children who are duly involved with both the child protection system and our youth justice systems around the country. What we do know is that once children come into the attention of child protection services, and that might be for reasons of abuse or neglect, or indeed parental incapacity, including parental incarceration or death, they're at least 9 times more likely to later come in contact with the youth justice system. Across Australia at any one time, at least 50% of the children in youth detention in custody are known to child protection services. So this is not a not significant overlap, particularly from the youth justice side of the system. Often this group of children would have had multiple child protection reports over an extended period of time. And in terms of their youth justice contact, we know they experience an earlier onset of that contact and tend to unfortunately become more entrenched in that system and are more likely to progress to the adult criminal justice system for a range of reasons. But what I really want to focus on today is the role of problematic substance use in the life of this group of children and in their trajectories. So in terms of our case file audit that we conducted with over 300 crossover children in Victoria, which were across metropolitan and regional courts, these figures above show just how high the prevalence is of various adverse childhood experiences across this cohort. More than 3/4 of them had been exposed to things like parental separation and divorce, family violence, and significant numbers exposed to household substance abuse, neglect, physical abuse, and so forth. One thing that really surprised us was just how high the proportion were, 1 in 5, who had experienced parental death during childhood or adolescence. It wasn't just that the children and young people that we looked at had experienced just one of these or 2 of these events. Substantial proportions had experienced what we call cumulative harm or cumulative adversity, not only in the number of times they experienced each one of these events, but in terms of their concurrent experience of these events. So 1 in 5 children had experienced 8 or more of the events listed above. And that, I guess, is important to bear into mind, particularly when they come into contact with a range of other services and systems, whether it's education or in the case of what we're talking about today, particularly drug and alcohol services. In terms of their parents of these children, we looked at whether parents had experienced substance abuse themselves, and we found that 7 in 10 of the children whose cases we looked at had grown up around substance abuse in their families. What was really interesting was that similar percentage in terms of that 70% figure was found by Matthew Wilson in his Victorian Children's Court study that also looked at what proportion of families presenting to child protection courts did so in relation to parental substance abuse problems. In terms of the crossover children we looked at, 1/3 of them had both biological parents experiencing substance abuse problem, and these figures were substantially inflated for First Nations children, of whom nearly 9 in 10 had grown up around some kind of household substance abuse. The nature of the substance abuse among children's parents really varied. It was anything from long-term cannabis dependence to severe polysubstance abuse. So it wasn't any one thing, and quite often we also saw some parents had actually addressed substance abuse issues and also become, substantially more available to children. But what we also saw in terms of parental substance abuse is it often co-occurred with other difficulties, particularly family violence and criminal justice involvement, but also sometimes mental health issues, also substantially overlapped with cases of child neglect. Sorry, my computer's telling me it's about to restart. That wouldn't be a good time for that. So what we also saw in relation to this group of parents was they often had their own histories of unresolved grief, trauma, and substantial disadvantage. And you could really see how these pathways led to that intergenerational trauma involvement. Some children themselves were born substance dependent due to in utero exposure to substances, and was also pretty apparent how parental substance abuse problems impacted parent-to-child bonding. Children were sometimes, unfortunately, exposed to dangerous, frightening or harmful circumstances related to their parents' use of substances. Circumstances, for example, such as finding a parent overdosed, either fatally or non-fatally. In terms of the children themselves, they also harboured quite complex support needs. And by complex, we mean multiple and interrelated support needs. 79% of them had been in out-of-home care at some point. So that might be kinship care with relative caregivers, foster care, or for a large proportion of children, residential care environments, which are staffed group home facilities with other similar young people. 74% had some indication of problematic substance use on their files themselves, and 61% had experienced a mental health diagnosis. A rather high proportion, nearly half, had some kind of indication of neurodisability, so intellectual disability or ADHD, autism spectrum disorder. A third had experienced school exclusion, so either expulsion or suspension, largely related to challenges children had regulating their own emotion or behaviour. Over 1/3 had indications of self-harm, suicidal ideation or suicide attempts, and 12% had some indication of sexual exploitation or risk of sexual exploitation in their file. In relation to that last point, we conducted a separate little investigation looking at the issue of sexual exploitation and criminal exploitation that I'll speak to later. But in terms of children's substance abuse, like their parents, it really varied considerably. Some of it was opportunistic use of drugs, of alcohol or cannabis. Sometimes it progressed to regular alcohol, cannabis use, and then in the more extreme cases, severe polysubstance abuse or alcohol addiction. Clinicians will often know that this group of children, young people, might not know what they're taking in terms of substances, because these can often be provided by older youth or adults or indeed other young people they might be living with, which complicates the issue of understanding how that might impact them and what risks they're actually taking. Substance use in this cohort commenced from quite young ages, 9 and 10 years old. We saw examples of children arriving at school intoxicated. Regular cannabis use by age 12 or use of ice or heroin by age 14 is not that unusual in this cohort. In terms of the overall group, we saw at least 40% of children had used either ice, other amphetamines, heroin or inhalants. And in terms of the outcomes and the risky outcomes that were seen for this group, sadly, we saw examples of drug-induced psychoses and even acquired brain injuries at quite young ages, from excessive use of alcohol. Like in broader cohorts and studies that look at the links between childhood adversity and substance abuse, the links between these two things are very apparent in this cohort, in that, the more the child had experienced adversity, the greater likelihood they were of using drugs problematically, and certainly the greater likelihood they were of using certain drugs in high-risk ways, or using certain drugs like ice, heroin or chroming. So we saw higher incidence of that with things like children that experienced parental death, where there was cumulative maltreatment, so exposure to a range of different maltreatment types, and where there were mental health diagnoses. So really apparent that there are strong and enduring links between substance abuse problems and experiences of childhood adversity that have been now replicated over a range of cohorts across a range of countries. But when you looked in children's files, you often heard these written statements made by children or comments made by children about why they use substances. And again, this really illustrates how this relates back to their experiences of adversity and trauma. Children spoke about blocking stuff, using substances to block stuff out, to escape, to sleep, to cope, to self-medicate, to numb feelings, to feel invincible. And from those kinds of comments, we can see that for children themselves, at least initially, substance abuse is far from being experienced as a problem, but rather it is often experienced as a solution to unresolved inner distress and external distressing circumstances. One of the young people I spoke to many years ago for a study I did, he'd grown up in residential care and he'd progressed through the youth and adult justice systems and had an experience of heroin addiction, said that how services could help would be by looking at my drug issues instead of just processing me as an offender. They needed to look at why I was offending, because I was on drugs and I wasn't happy where I was at. I think you've got to look more to why he's doing it instead of he's doing it, we'll give him the consequence for doing it. So how exactly does these experiences of trauma and substance use relate to offending behaviour in this kind of a cohort? What we saw for children who used substances problematically in particular, there was an increased prevalence of all kinds of offence types. It wasn't related to the particular kind of offending. Definitely linked with children who started offending at earlier ages, and it was a predictor of a greater number of offences. The kinds of circumstances we sometimes saw were a particular precipitating event, the child getting kicked out of school or entering residential care or losing a parent, leading to a very sudden escalation in substance use and offending, and heading off on that kind of a trajectory. The other particular associations we saw between substance use and offending were children who offended during substance-related disinhibition. So this often related to things like alcohol-related assaults. There were specific drug offences that some children were charged with, for example, theft of alcohol and using cannabis. And that's quite an interesting point there in terms of the use of cannabis. A recent Sentencing Advisory Council study in Victoria showed that children in residential care were much more likely to get charged with a use of cannabis charge than children who had no contact with child protection services. Now, we know a range of children will experiment with substances, so there's a degree of questioning as to the level of surveillance and the impact of surveillance on this particular cohort in terms of their drug-related offences. Children were also often offending to repay drug debts, often again to older youth and adults, and this facilitated a level of exploitation of this group of children by older youth and adults, which we conducted some further research and examination of, and it was very apparent that in this particular cohort, substance use is often used as a tool for grooming children and young people in relation to then later sexually exploiting them and criminally exploiting them. We published this paper last year from our study, which demonstrated that there are particular vulnerable cohorts of children in contact with the child protection system in terms of the risk of criminal exploitation of this group, and that were children with neurodisability and children in residential care contexts. This paper was cited recently by the Victorian Commission for Children and Young People in their out of sight inquiry, which was looking at the issue of children going missing from residential care in particular. And the Commission made recommendations for police to take more proactive action to disrupt and respond to the criminal exploitation of children in these kinds of contexts. But again, substance abuse being a key facilitator of those kinds of really problematic outcomes for children and young people. So what might be the implications of some of this? And I'm stressing that this is not the only implications, but just some things to think about. Well, clearly we know now that are links between cumulative childhood adversity, substance abuse and justice system involvement, both in terms of the youth and adult criminal justice system. This will in no way be unfamiliar to people who work within these systems, work within the courts, out-of-home care systems, a lot of drug and alcohol services, particularly youth-focused services and youth justice practitioners, but encourage us to think more broadly about how we frame the issue of substance abuse and addiction in our community and in our society to really take account of these disproportionate adversities that people tend to have experienced. There's a need to consider children who end up in these circumstances and with these outcomes in the context of their families and their social contexts, as well as considering their parents, adults, not only as adults in substance abuse systems or services or within the justice system, but also as parents, and to understand that to the extent and in the nature that we respond to those parents will filter down to their children and to the next generation. There is certainly a need and a recognised need for trauma-informed and trauma-specific models that can respond to addiction and problematic substance use where needed, but also a need for systems and services to be able to be engaged and respond to complexity and diversity within these groups, because where they are unable to, it is certainly the most vulnerable, the most disadvantaged children, young people and parents that will be most likely to be excluded from those services. So I'll leave it there. I'll provide some references, and I'm sure we'll be able to get these slides to people who are interested, and it also has my details there. And I will now pass on to Debbie.
Just share my screen. Okay, thank you for that, Susan. That's such an interesting perception of the way things happen and really leads well into what I wanted to talk about today. But before I start, I'd like to thank the organizers, first of all, for the invitation to speak today and to acknowledge the Wadawurrung people of the Kulin Nation. I'd like to pay my respects to their elders, past, present, and emerging, and acknowledge any First Nation people who may be attending today. So Susan's already painted a really great picture of the prevalence and impact of child protection and the importance of appropriate and timely intervention and how adult systems can intersect with child protection systems. And globally, it's common to hear how adult services, including alcohol and drug, mental health, even antenatal systems, need to work together with child protection. Generally, when they're talking about child protection in this context, they're talking about the formal child protection department, the government-funded department that mostly deals with child protection with some support from NGOs to help deliver services. But that's more of a challenge than you might imagine at first. There's differences in models of care and in who the client is and the rules of engagement around those clients. So if we start by looking at some differences between the two systems, adult services, funnily enough, focus on adults. Often the engagement is voluntary, it's self-identified, and there isn't a threshold of severity before services of some sort can be offered. For the most part, if you have an alcohol and drug or mental health issue, no one is mandated to report your behavior, except, for example, in cases where it intersects with other systems, like, for example, drink driving. Usually services are prepared to accept that engagement may require long-term work and or multiple attempts for recovery, and there's flexibility around that. If someone decides to opt out of treatment, there's usually an open door to allow them to walk back in if they choose. And the relationships for these adult-focused services really rely on trust. Child protection, on the other hand, has a necessarily different model of care for obvious reasons, but much of the difference is also situated around the structure of the formal child protection system. Today's system evolved in response to a pediatrician and a radiologist identifying the co-occurrence of long bone fractures and head injuries in children back in the 50s and 60s. Since that time, neglect and emotional abuse have become more common than physical abuse, and numbers of reports have increased exponentially, resulting in a system that's buckling under the pressure with high caseloads and high levels of staff burnout. Most importantly, the child protection system is child-focused. They respond from a best interests of the child perspective. There's legislative requirements for intervention that require a threshold of harm, and that must be indicated. And in most jurisdictions, there are requirements for various professionals and people who interact with children to report their suspicions of maltreatment. Once reported to the Child Protection Department, the child protection practitioners triage or assess and decide if the reported issues meet the threshold for their intervention. If not, parents may be offered different responses. For example, a differential response intervention that provides parents with a voluntary engagement with things like triple P or PUP, for example. If the threshold is met, then the case is deemed to be substantiated, and there are various orders that can be put in place via the court system to protect the child. The family may be required to engage with the department under the supervision of the department, and the children may be placed in the care of a foster carer or another family member for a period of time until the department is convinced that the children are safe, or longer-term orders can be implemented if the concerns are that a longer time is needed to address them. In most jurisdictions, there's a limit on what this time is, somewhere between 12 and 24 months before a permanent care order can be issued to terminate parental rights. There's been a growing and actually quite long-term groundswell pushing to moving from this forensically driven response to a public health model with early intervention and an aim to prevent child maltreatment before it occurs. But what does that look like? Firstly, it involves identifying risks in the population and minimizing those. Risks like young maternal age, unemployment, family violence, alcohol and drug or mental health issues, as we've heard from Susan. Things like disability in a child or chronic health issues. Often these risks occur in conjunction with social isolation. So we know that if we intervene early in these and provide systems universally across populations, things like childcare, income support, employment placement services that anyone can access, there's a likelihood that that will reduce the risks and prevent child maltreatment completely. We also know that we then move to the secondary support for children. So this is for families where there may be a risk of child maltreatment. So for example, very young moms who have children before they're 22 that's been shown to be a risk, or families with a child who has a disability. We can provide support services around those issues rather than focusing on the maltreatment. And by addressing those risks, we can prevent the child maltreatment. And finally, then the tertiary response is about minimizing the effect of the maltreatment and preventing further maltreatment. This is the current child protection system response for the most part. And I know there's situations where this changes slightly, but I'm talking from a broad perspective. The important thing to see with this is that these levels aren't clear cut, and often a family can be involved in all three levels of support at once. So I won't go into this in detail, and Susan really has described a lot of this already, but it's illustrative of the impact of maltreatment. It can last a lifetime. There might be short-term injuries that need to be addressed in physical or sexual abuse, but then we see longer-term impacts. And we know that once a child has been maltreated, they're also more likely than others who haven't to be the victim of bullying, dating violence, and as adults, interpersonal violence and intimate partner violence. But I think what's evident here is that the impacts of maltreatment end up in adult services to deal with the trauma, alcohol and drug, mental health, suicide, and association with the criminal justice system. And again, I won't go into too much detail here, but these are things that are protective for child maltreatment: good health, supportive family environment, stable housing, access to services. So actually, the impact of maltreatment is bidirectional. If we support children and prevent maltreatment, they won't require the longer-term intervention of adult services. And if we support adults who have experienced maltreatment, they will be better able to care and protect their children, and then they won't need the services longer term. There's been years and years of work toward this model of child protection, but one of the biggest issues around this is who's at the table when this reform is discussed. Primarily, it's only child protection, and to really move to a true public health response, we need a multidisciplinary team at the table, one that represents both adults and children and aims to support families in a holistic manner. For instance, to address alcohol and drug issues, just as an example, in 2009, work by Dorothy Scott found that 13% of children lived in a home where parents drank at harmful levels. And now we know that that's probably even increased from there. And we also know that the services alone, the alcohol and drug services and mental health, can't address this problem on the scale that's needed. So there's acknowledgement even then that child protection had to work with alcohol and drug organizations, but also that we needed population-based measures, things like restricting alcohol advertising, minimum unit prices, taxes, social marketing about the harms of alcohol, all needed to be included. And more, funding models need to take into account how all of these can work with services and have services to be funded in a way that isn't based in silos and allows collaboration. So what has to happen to see this collaboration? Research across a number of years has shown that child protection and adult service delivery organizations want to work together. For the most part, their goals and aims are the same, but there are impediments to making this happen easier. Issues include fear of destroying a therapeutic relationship, so not wanting to report that there may be an issue around child protection because the parent will disengage from the service that they need, reporter fatigue, or conversely, fear of consequences of reporting. So this can involve, in small towns, some research I did a few years ago looking at emergency departments, a fear of someone seeing who the reporter was, and so not wanting to be identified because they knew that the aunt of the child or the cousin of the child worked in the hospital where this documentation was likely to be seen by that person and the reporter would be identified. But also fear that either I keep reporting and nothing happens, the child protection system doesn't intervene, or conversely, if I report this, child protection is going to swoop in and remove the children, and then it's just going to make it worse for my adult client. So not understanding how process and thresholds work is actually an impediment. Funding models don't allow time for collaborative work. If you're funded to deliver alcohol and drug services, trying to deal with parents about parenting is hard to manage on the restricted time that you have. We also know there's a great deal of importance attached to information sharing, and NAMHSU is going some way to addressing this, but some research that's been done recently between alcohol and drug and child protection services has found that really very few people have applied those NAMHSU guidelines or are confident about what they need to do to share information, who they can share with, and what they can share. So the other thing that's really been identified is that we need MOUs between organizations that identify lead agencies, and the roles have to be outlined because we need someone to take the lead and not have people fall through the cracks. In 2009, Dorothy Scott published this paper, and I'd love to leave it as D. Scott, but Dorothy's a bit of a legend in the child protection space, so I can't take the credit for it. I'd love you to think I was the clever one, but this was Dorothy's work. This model talks about how adult service organizations can work with child protection authorities, and the model paints a great picture of the levels this needs to happen. She suggested that the collaboration has to be defined and facilitated at each of these levels. The individual level, where the collaboration has to be defined by the institution with sanctions to make sure that responsibilities are fulfilled, and guidelines for individual practitioners on how to go about engaging with child protection. At the organizational level, there may be subcultures and work pressures like caseload and agency philosophy, or performance indicators and risk aversion that actually work against collaborating with child protection. And part of this often goes to the funding and the time allocated to do the work. Policy in the bigger context shapes organizations and individuals. If the whole of government response is strong, then more joined up service delivery is possible. Funding models and competition for scarce resources become easier to manage. So ultimately, the organizational history, professional boundaries, workforce skill limitations, and narrow performance indicators and funding models are among the factors that constrain the ability of adult services to respond to the needs of parents and their children. Oops. So sorry, I've already said that. I'll move to the next one. My key messages are that families matter. You can't treat an adult parent without considering the impact and benefit of the children. And conversely, if you're dealing with the children, you must also consider the needs of the parent. The impact of addictive disorders, mental health, and family violence and child maltreatment are bidirectional. By impacting on one level of service delivery, you will ultimately impact on the other. And finally, the sectors want to work together. They just need to be provided with the frameworks and structures to do so. And these are my details if you have any questions or would like to get in touch with me. Thanks very much for your time, and I will pass over now to Christine.
Thank you so much, Debbie. I'll move into my section now. Can you see the slides?
Yep.
Hopefully. Yep, perfect. Thank you so much. So thank you so much, Debbie and Susie, for sharing your experiences and research with us. I'll bring together some of the key messages that came out from both of their presentations and some food for thought as well as we move into the last part of today's session. If you do have any questions, please pop them in the Q&A box and we'll get to those at the end of my next sort of 5-minute wrap up. And we definitely will get to your questions as well. So if you have anything that you think, oh, should I ask? Absolutely ask us. We'd love to hear from you as well. So I think from what we can see, and as an educational psychologist working in some really at-risk schools across the state of Victoria, in particularly bushfire-impacted regions in Gippsland, we do see multiple layers of trauma. And the intersection in that can be challenging for families and particularly children. I mean, both Susie and Debbie raised that bi-directional impact that can happen for these families and children too, and also caregivers in these circumstances. I often see it being a consolidated impact. There are uncontrollable environmental impacts, for example, COVID-19 having quite a big impact on trauma that's already occurring in children's lives. We are seeing more challenge with the changes in lockdowns and the circumstances of COVID-19, as well as particularly challenged communities that have been impacted, for example, by the bushfires that occurred in 2020. So we often see co-occurring issues where we're seeing categories of childhood trauma across different areas impacting a young person and their caregivers. Important to note that the work that I'm looking at in schools, it has a particular detrimental impact to learning, engagement and academics. And if students are dramatically impacted by trauma and multiple events, it can negatively impact even their attendance in school and ability to engage in their education as well. So I have just been commissioned to work with the Department of Education to look at trauma-informed and sensitive practices to support students in education around some of these traumas, and what can we do to support these families that are directly impacted. The evidence sits at the moment, and Susie touched on this in her work as well around the implications, is having trauma-sensitive approaches and responses. Now, for some, this can feel like a buzzword, or everyone says we need to be trauma-informed, but the evidence does weigh up. I'm happy to send through that research around using trauma-informed approaches to support youth and organisations as well. So it is supposedly very helpful, and I have seen this in practice, for burnout and prevention of burnout in the workforce as well. So it is about recognising that complex layer of trauma and how it is co-occurring. Both Debbie and Susie went and unpacked the layers of trauma and the impacts that can have, but it doesn't mean that you need to learn how to directly treat trauma itself. It's about having that knowledge and acknowledging and understanding the impact that layers of trauma can have in a young person's life. I mean, it's not an add-on approach, but it's a way of working and communicating with children and their peers, as well as caregivers and staff as well in the community. So just a little summary around awareness, and it is around looking at traumatic experiences and how they have an impact on the individual person, but also how they can then extend to family members and also first responders and medical professionals. So areas where we do see high risk children engaging in services, there is a ripple impact of trauma occurring in some of those situations. And so being aware of that trauma and recognizing it can be helpful in reducing some of those trauma triggers occurring as well. So as I mentioned, realizing the prevalence of trauma and how common it is, as well as recognizing how it affects you and your work, as well as then how you might then actually respond to children in care or who have had multiple layers of trauma occur in their lives as well. So we can do that through safe spaces. Some of this might be, pretty obvious, but communities of collaboration and working in a multidisciplinary team. So for example, just today, I'm from the education faculty and an ed psych. Debbie's working in a different area, and Susie's in social work. So coming together to address some of these difficult challenges is where we need to be moving towards. Using strength-based questioning in our approaches is part of a trauma-informed practice. And it's looking at it from right at the beginning, from reception, moving into anyone who has direct contact with clients, including administration and supervisors being trained in a trauma-informed approach to support that knowledge and lens of the ripple impacts that trauma can have in communities as well. So in summary of what we've talked about today, with trauma, and I do want to sort of leave a message of hope in there too, that with supports and trauma-informed approaches, most children and adolescents can return to previous level of functioning or develop new ways or healthier ways to function, even in the midst of going through a traumatic circumstance currently. But a caveat is that it is complex and it is challenging for providers to be able to offer supports, especially for some where the system itself can be triggering and contribute to trauma experiences. So we do need more research and education that acknowledges this complexity and the challenge of this collaboration and working together to address some of these challenges as well. But we do need to start somewhere. And so I know for all three of us, we are more than happy to connect in with anyone from today's webinar so we can build in collaborations to address and acknowledge some of these complexities as well. So in wrapping up, I just would like to point out, if you do feel like you have been triggered by anything we've shared today, the Blue Knot helpline is fantastic to connect in with. They open business hours, Monday to Friday, and then on the weekend as well. And then, you know, the usual Beyond Blue lifeline and alcohol and drug support if needed as well. And there are our contact details if you would like to get in touch with us. If we don't get to your question in our last 10 minutes, we'll be asking questions to our presenters. Please email us directly. All three of us have said we're happy to share our contact details and keep the conversation going after today's webinar as well. So I'll stop sharing and move into looking at some of our questions that have come through. So the first one is for you, Susie, from Jordan. His question, Jordan's question is asking around similar outcomes and issues occurring for crossover children who may not be in statutory orders, however, might have both youth justice and CP involvement.
And I assume similar outcomes issues is in relation to drug and alcohol outcomes, but it might be a broader range of outcomes. What we do know is that in terms of the children involved with the child protection system, the further that the child has penetrated into that particular system, the greater the likelihood of them crossing over into the youth justice system. So where there's just been where there have only been notifications or substantiations, they're less likely to then come in contact with the youth justice system compared to children, for example, who are in residential care contexts or who have those statutory child protection orders. But yeah, there is certainly something to say about the experience of having that statutory intervention itself, and certainly the experience of entering out of home care being a really significant life experience, and for a child or a young person, one that can have significant implications for what they need to process emotionally. It might be about grief and loss. Often children might enter that system because parents have died, parents have become incarcerated. So there's often a lot wrapped up in that process of entering out of home care in the first place. Having said that, sometimes some children, it might be that they've come from a rather, complex or destructive environment, and then being able to be placed in a kinship care environment with an auntie or an uncle, and that they might experience that as being more safe and more settled. So I don't want to kind of make any broad comments about that, because each child's and young person's experiences of becoming involved in that system will be quite different and unique, and be associated with a range of kind of opportunities and challenges.
Awesome, thanks, Susie. And I think there was a follow-up question there around, in your opinion, do you think there could be specific psychological or developmental impacts as well for children in these areas. Did you answer that? You might have.
I can answer it more though.
Yeah,
Let me answer
I reckon
it more.
you could add it and then add to the second question too.
Because I think that this is often quite poor. Well, it's recognised by some people, particularly out of people that are practicing in the out-of-home care fields, especially when a child has suddenly entered residential care in particular, or foster care. You know, there will often, after a period of maybe relative quiet, there can be a period of testing behaviour, escalation in the child's behaviour, largely around, gosh, what a traumatic experience to move into a completely different environment. I don't know the people, I don't know the rules, and that can lead to some behaviours where, if it's not recognised that that's part of, you know, a really challenging transition for a child or young person, you know, at the poorest end might be met with a criminalising response, might be met with a response that's, you know, not as trauma-informed as we would like, that can, again, have really more detrimental impacts for the child or the young person. So absolutely a significant life event. I think I've certainly seen cases where, you know, a child might have entered residential care and behaviours escalate. It's met with a criminalising response, unfortunately, but then magistrates have taken a look at the child's file and seen, well, you know, this child's just entered residential care, they're having some troubles, you know, and largely written off the charges and let them go with the understanding that the child's going through a difficult time. But even the response in itself, even if it doesn't end in a criminal justice outcome, having that kind of response from adults who you want to be, you know, caring for your well-being and responding to you with care and compassion, and, you know, who hopefully should have some understanding of trauma and development, that in itself can be quite criminalising. When we talk about traumatising systems, that's the kind of thing I think we all want to be avoiding.
Fantastic. Thanks so much, Susie. And I think both Jordan and Kylie have popped in a comment saying thank you very much for your response. And we absolutely agree that we're paying attention to this space and doing this work, because often we don't hear people talking about their complexity. So it's great to get us all together. I might move to Debbie. This question came through when you were presenting your bit. Where does the family reunification order sit in this? Both AOD and ACCOs have this already.
Okay. I'm guessing you mean around the, is this to do with the time limitations on terminating parental rights? I think I'm assuming that's what this relates to. My understanding is that this termination was brought in order to try to provide some stability for children who were being moved from home to home. And the system was designed to try to help provide that stability. And as Susan said already, being in out-of-home care in and of itself isn't always a bad outcome. Sometimes it's a really good outcome for kids. It can be bad, but for some kids, it's actually exactly what they need. So I think we have to go back to the individual child and look at what the circumstances are for the child. And for some kids, they may never be safe at home. And we have to acknowledge that and do the best we can and provide as best as we can for those children and give them the opportunities they need. But I think it's really important that our first step starts with a belief that we can find a way around this, and working closely with the family, and not just assume that, for instance, if there's severe alcohol and drug issues in the family, there is no hope. Being prepared to give a little bit of leeway and find a way to work closely with those organizations to get the best outcome for children.
Fantastic.
I hope that answers it.
Yeah, thank you. Fantastic. Thanks, Debbie. Another question I'll move to both of you. Could you please speak to how service providers can respond to the safety of children and young people when there is insufficient readiness in both parents and young people to engage around substance use, given that recovery from addiction depends so heavily on readiness?
Do you want me to start with that, Susan?
Go for it.
So I think this, again, this comes back to some of what Christine was saying earlier, and certainly what Susie was saying about we really need to start from a position of collaboration. And right now, the systems and the structures are not necessarily there to make this happen easily, but we hear stories all the time of parents who are doing their best, and the child protection system is putting restrictions on them, like you must be in a suburb on the other side of town for alcohol testing, and it has to be that you're abstinent before we can even consider this. that we need to be working more closely with alcohol and drug services and recognizing the small gains that parents are making, but also alcohol and drug services working openly and transparently with parents to give them that opportunity to make those changes and still keep the children safe. Susie, from a social work perspective, you might have a better answer for that.
The only other thing I can think to add there as well is that we do have certain models that are showing promise in terms of, you know, if we have to end up at the adversarial end, at the interventionist end of the court system, we know that there's, for example, in Victoria, we've had the family drug courts put in place, and they've started to include things like peer helper models in those systems so that parents can feel less stigmatized and more supported through that process, and that someone has walked in their shoes before them and can understand some of the challenges. I definitely agree that there's a lot of pressure on parents where there might not necessarily be service access available. So we can, you know, talk about readiness, but we also, on the other hand, need to ensure that not only a service is available, but the right services that can deal with kind of the complexity of needs, whether, you know, that might be a culturally appropriate model, for instance, in terms of the drug and alcohol services. So I think readiness can also be influenced by the perception of whether the services feel right for the person as well. That might be part of inching people towards readiness, is feeling that the process is accessible, that it's non-stigmatizing, that it's supported, and so forth. So I'm wondering if it's kind of in hand with the models and the way we approach people can actually support that pathway to readiness. But granted, I don't want to minimise the complexity of such a process and the risk that people sit with and have to consider in these kinds of decisions, because it is undoubtedly incredibly complex.
Thank you, Susie and Debbie. And Matthew's just shared a link in the Q&A around family drug treatment court program. That looks great. So thank you for sharing that, Matthew, for everyone to access. We only have a couple more minutes left, so I'll move through to maybe Kieran's question. And I would just like to reflect that absolutely I will share a bunch of links for trauma-informed practices and approaches that we use that you can have a look at after this webinar. So I'll add that into the slides and the PowerPoint so you can have a look directly at some of those resources to learn more about how to actually support children with disabilities who are in these situations too. So I will add that in, Eliza. So from Kieran, understanding trauma is important, especially for neurodivergent impairments. How can we ensure that child protection and drug and alcohol services are informed about neurocognitive impairments?
Do you want me to kick off? Yeah, so this is an incredibly important intersection. I have just recently, in the last few weeks, been commissioned by the Disability Royal Commission to lead a team of researchers that are going to put some work into understanding the nexus of disability, child protection and youth justice. So there is certainly a recognition that this intersection is incredibly complex and is incredibly overlooked, and even more so for First Nations children, for whom disability services are not necessarily framed in culturally appropriate ways or culturally sensitive ways. So it's certainly a huge problem, and I agree with Karen's conclusions there. I also think we see the same issues in the youth justice system, where there is an over-reliance on cognitive behavioural strategies which are not responsive to the needs of children who are neurodiverse. And it's an incredibly problematic area. I know that there's a lot of more research kind of going into this area now because it's been increasingly recognised, especially the issues of FASD. But, you know, it's for the crossover kids that we looked at in a regional court, 25% of those children had an intellectual disability. This is not insignificant numbers of children that are presenting with, you know, neurocognitive impairments at these intersections. And so to not have appropriate responses, both in a treatment sense and in a rehabilitation sense for that group, is incredibly problematic and will lead and continues to lead to poor outcomes for those children, for their families and for the broader community. So it's certainly something that warrants more attention.
Thanks, Susie, and I absolutely agree with both your point and Karen's point that the current approaches that we use in psychology don't necessarily help because they aren't trauma-informed. As, for example, CBT is an approach that might be recommended for kids in these situations and crossover kids. That is not the best approach. Actually using, as Karen has mentioned, trauma-informed practices and understanding the complexities in that intersection too is critically important for large cohorts of these kids going through these experiences as well. So we have 1 minute left, so we'll get to Linda's question, which is awesome, or reflection really, to both Debbie and Susie. So Linda has working with a family who's a single mum and struggling. Children are refusing to attend school, spoken to child protection. However, the children are putting themselves at risk through drugs and vandalism. Any reflections you'd like to share on that case, Debbie and Susie?
I think Susie might be better placed to respond to this because it sounds like a real social work.
It's again,
focus.
you know, these are the kinds of things that, you know, we would like to have the capacity to be responding earlier, you know, like the question, the person posing the question, we know that early intervention is better, and what we unfortunately continue to see too much is that children need to wait till they get to the youth justice system, till they, you know, get to the pointy end of things before we then implement a service response and a support response. And it is not desirable. And I think that the overall thing that we need to be moving towards, as Debbie said, is more of a public health model where we can access services. We don't have to wait till there's some kind of statutory intervention or some serious event for children and young people and families to be accessing services they need when they're struggling.
Thank you. And we will hand straight over to Tina because we are right on time. And I'm sure Susie, Debbie and myself could keep you all afternoon, but we need to stick to time. And I'll hand over to Tina to wrap us up.
Thank you so much for that, Christine. So on behalf of the Monash Addiction Research Centre, I'd like to thank Susie, Debbie and Christine for such a powerful and thought-provoking session. I did see there was a question in the Q&A around whether this webinar would be shared. So if there was something that you missed or you have a colleague that you think might be interested in this topic as well, this webinar will be available via YouTube early next week. You can find our YouTube channel by searching for our name, the Monash Addiction Research Centre, and there on the channel you'll be able to catch up on any of our previous sessions as well. See you next time.